Hello, my dear students. So I am here today to discuss some of the important topics from dermatology, and we will try to understand these topics with the help of these few questions. Okay, so we'll be discussing these questions along with the related topics so that you can understand these topics well. And because your exam is very nearby, this session will be helpful for all of you. So let us discuss the first question here. This question is related to histopathology. So in this question, they are asking that acanthosis is characterized by. So acanthosis is characterized by. Now, what is acanthosis? Acanthosis is thickening of stratum spinosum. So increased thickening of stratum spinosum is known as acanthosis, while loss of adhesion between keratinocytes is known as acantholysis. So acantholysis, lysis as the name is suggestive, is separation. So acantholysis occurs in pemphigus. It is also seen in other conditions like Hailey-Hailey disease, Darier's disease. While acanthosis, that is thickening, it can be regular or irregular. Regular thickening of stratum spinosum is seen in chronic eczema, psoriasis, while irregular thickening is seen in lichen planus. Now, if you see the third option, they are saying presence of nucleus in stratum corneum. So presence of nucleus in stratum corneum. So normally this topmost layer, that is stratum corneum, don't have nucleus. But if nucleus is present here, that is known as parakeratosis. And parakeratosis is feature of many conditions including psoriasis, eczema, actinic keratosis. Here you can see that this is how the normal thickness of stratum spinosum is, but when it gets thickened to a larger extent, we call it acanthosis. These are the layers of skin like epidermis, dermis, subcutaneous layer, which is also known as hypodermis or panniculus. And in between epidermis and dermis is basement membrane zone or dermoepidermal junction. Now, do you know that among these various layers of epidermis, which one is the thickest layer? The thickest layer is stratum spinosum. While stratum granulosum, as it is suggestive, is the granular layer, here granules are present. And these granules are generally keratohyaline granules and lamellar granules. Sometimes they ask you question on lamellar granules. So remember, lamellar granules are also known as odd-land bodies. Odd-land bodies. And what these odd-land bodies do? They secrete lipid, while keratohyaline granules form prefilaggrin. These are various layers of epidermis. As you can see, the topmost layer is stratum corneum, then is lucidum, then granulosum, then spinosum, and then basal layer. These are the 5 layers of epidermis, and this is their sequence. The first one is corneum, the last one is base, and in between are legs, that is lucidum, granulosum, and spinosum. And the important cells which are present in these various layers are keratinocytes, which are among around 95% of the cells forming epidermis. Then there are Langerhans cells which are present in stratum spinosum, and melanocytes and Merkel cells which are mainly present in basal layer or the deepest layer of epidermis. Melanocytes, they synthesize melanin, while Merkel cells are helpful in carrying touch sensation. So these are touch receptors. While Langerhans cells are antigen presenting cells. So these are few important points related to these layers and the cells of epidermis. Now, in the dermis, collagen is present. And sometimes they ask you, what is the type of collagen which is present in dermis? So, collagen are the most abundant fibers present in dermis. There are two types of collagen present here, type 1 collagen and type 3 collagen. Now, which one is more? So, remember that type 1 is more than type 3 and their ratio can be sometimes up to 8:1. So in these options, you can see that type 3 is not 100%. They are not equal. And type 3 is not more. The more one is type 1. So most abundant fibers present in dermis are type 1 collagen fibers. And among these four options, the best option is option A, that is 70% of collagen 1 and 15% of collagen 3. Collagen is the most abundant fibers present in dermis, but other than collagen, you can also find elastin, hyaluronic acid. So there are other fibers also, but the most abundant fibers are collagen fibers. Then there are cells also present in dermis. The cells present here are fibroblasts, which are most abundant cells. And there are mast cells as well. As you all know, mast cells which release histamine and can lead to certain conditions like urticaria, urticaria pigmentosa, all these conditions are related to mast cell. Then sometimes they ask you about Huxley and Henle layers. Now, there are many layers of skin. Like I told you in epidermis, there are stratum corneum, lucidum, granulosum, spinosum, basal layer. These are the layers of skin, or more specifically, epidermis. Then hair follicles also have certain layers, and Huxley and Henle layers are actually the part of hair follicles. So if you see the cross section of hair follicle, or if you cut the hair follicle transversely and look at various parts of the hair follicles, it will appear something like this. So you will find that it has outer cortex and inner medulla. So here you can see this is medulla, which is the central part, and then there is cortex. Then outside cortex is cuticle. So this is cuticle. Then comes inner root sheath and outer root sheath. Now this inner root sheath is made up of three layers. Cuticle is included in inner root sheath along with Huxley layer and Henle layer. So outside cuticle, you will find Huxley and Henle. So these are various layers of the hair follicles, and then comes the outer root sheath. So it is very easy to remember. Central medulla, then comes cortex, then comes inner root sheath which have cuticle, Huxley and Henle layers, and then comes outer root sheath. These are various layers of the hair follicle. Sometimes you get confused that which one is inner, which one is outer. So among cortex and medulla and among Huxley and Henle, you can see that they follow alphabetical order as we move from outside in. So if you move from outside in, among Huxley and Henle, which one will come first? So they follow alphabetical order. So you can see that Henle and then Huxley. So alphabetically E comes first and then comes U. Similarly, cortex and then medulla. So C comes first and then comes M. So they are following alphabetical order as we are moving from outside in. So Henle, then Huxley, then cortex, and then medulla as we are moving from outside in the hair follicles. So if they ask you the sequence, you can very easily mark that as well. Then there is a blistering condition which is known as bullous pemphigoid. Bullous pemphigoid is most commonly associated with which of the following? Now see, desmoglin 3 is the antigen which is involved in a condition known as pemphigus. To be more specific, it is involved in pemphigus vulgaris. While desmoglin 1 is also involved in pemphigus, it is involved in pemphigus vulgaris as well as pemphigus foliaceus. So remember that in foliaceus, only desmoglin 1 is involved, while in vulgaris, both desmoglin 3 and 1 are involved. But if both are given in separate option, remember 3 more than 1. Okay, so 3 is involved in vulgaris, 1 is involved in foliaceus, but remember that later on 1 also gets involved in vulgaris. So if both are given in separate option, 3 you will choose as the answer in vulgaris, while in foliaceus only desmoglin 1 is involved. Now coming to these two antigens, that is BPAG1 and BPAG2. Now do you know what is the full form of BPAG1 and BPAG2? This BPAG1 and BPAG2, here this BP stands for bullous pemphigoid. So these are bullous pemphigoid antigen 1 and bullous pemphigoid antigen 2. So you are very sure that the commonly associated antigen here are bullous pemphigoid antigen 1 and bullous pemphigoid antigen 2. But both are given in separate option. So which one you are going to choose? So remember that here both are involved. That is BPAG1 is also involved and BPAG2 is also involved. But if both are given in separate option, which one you will choose? 1, 2, 1, 2, 2. So remember 2 more than 1. So answer here is BPAG2 because BPAG2 is more commonly involved than BPAG1. Now these antigens have few more names, like BPAG2 is also known as BP180 because the molecular weight of this antigen is 180 kilodalton. Similarly, BPAG1 is also known as BP230. So maybe if a similar question comes and instead of 1 and 2, 180 and 230 is written, then you will choose 180. This is also known as collagen 17. So these are few more points which you can remember about this condition. Here you can see this is a patient suffering from bullous pemphigoid. Bullous pemphigoid clinically presents with, so in the clinical features, you will notice that this is a condition which usually develop in old age, that is around 60 to 80 years. So old individual presents with tense bulla. So large fluid filled lesions, and you can see that they are very large and tense. So large tense blisters with itching. So they have itching and perilesional erythema. And generally there is redness around these lesions. As you can see, there is redness around them. So there is red area surrounding them. And when they heal, so sometimes when these blisters start healing, you will find milia formation. Milia are nothing, these are small keratin cysts. So these are the clinical features which are seen in this condition. In old individuals, tense blisters with itching and redness around the lesion. And when the lesions heal, they leave behind milia formation. This is the characteristic appearance of bullous pemphigoid. Now they are asking about epidermolysis bullosa dystrophicains. Now this is a congenital type of epidermolysis bullosa. Epidermolysis bullosa is also known as mechanobullous disorder. Now, why we call it mechanobullous disorder? Because in this disorder, bullous lesion, that is fluid filled lesions, start developing where at the site of mechanical trauma, friction, or pressure handling. So how the clinical presentation is mentioned in the question? Generally, they mention that young child. Why young? Because this is a congenital condition, so it has early onset. This is a genetic condition. So young child presents with blisters or fluid-filled lesions where at the site of trauma, friction, or pressure handling, you are dealing with a case of epidermolysis bullosa, also known as mechano-bullous disorder. Now remember that this congenital type of epidermolysis bullosa can be of three types. The first type is the simplex variant. In simplex variant, keratin 5 and 14 is defective. So the genetic defect is present in keratin 5 and 14. Then the second type is junctional variant. In the junctional variant, laminin is defective. Laminin is defective. While the third variant is dystrophican's variant. And in the dystrophican's variant, collagen 7 is defective. So remember that collagen 1 and 3 are present in dermis, while this collagen 7 and collagen 4 are present in basement membrane zone. Basement membrane zone, that is dermo-epidermal junction, that is in between epidermis and dermis. And among these two which are present in basement membrane zone, in dystrophican's variant, collagen 7 is involved. So epidermolysis bullosa dystrophican's involves basement membrane zone or dermoepidermal junction, and the protein which is defective is collagen 7. As I told you that epidermolysis bullosa is a mechanobullous disorder, that is the blisters or the peeling of the skin occurs at the site of trauma, friction and handling, and that's why you can see that this young child or a neonate is developing peeling of the skin where over the frictional site where the heels are coming in contact with the surface. Similarly, wherever child tries to hold something, the friction occurs or trauma occurs, and there these blisters start developing. So this is a very severe condition. It occurs in very young individuals or young children, and they occur at the site of these trauma, friction, and pressure handling. Coming to the next question, they are asking about Darier's disease. Now, all these statements are related to Darier's disease except. So you can see in the question it is written all except. So it is very important to read the question very carefully. They are asking the correct option or the incorrect option. They are asking all are true or all are true except. So here they are asking all except. So you have to find out the odd one out among these four. Now, Darier disease is different and Darier sign is different. So remember that Darier sign is not seen in Darier disease. It is not seen in Darier disease. Now, corpse rounds and corpse grains are seen in Darier disease. Lesions predominantly are present over seborrheic areas. This is also correct about Darier's disease. And nails show longitudinal alternate red bands with V-shaped notching. This is also finding of Darier disease. So all these three statements are true about Darier disease, but which one is incorrect? And that is option A. So the answer here becomes option A. Now, if Darier sign is not seen in Darier disease, then where it is seen? So remember, Darier sign is seen in Urticaria pigmentosa. This is very important. Already question have been asked that in Urticaria pigmentosa, Darier sign is seen. Just now I will explain what is Darier sign. Before that, let us discuss what is corpse rounds and corpse grains. Now remember that if this is epidermis, so if this is epidermis of a patient suffering from Darier disease, in this patient, you will find that there are few keratinocytes which are transversely elongated and few of them are vertically elongated. These are known as corpse grains, and these are known as corpse rods. So what are corpse grains and what are corpse rods? These are transversely elongated and vertically elongated keratinocytes which are seen in the epidermis of a patient suffering from Darier disease, known as corpse grains and corpse rods respectively. Now, if you forget this point in examination hall, you can very easily recall this. Why? Because it is so easy to recall. See, alphabetically, which one comes first? G or R? G. So, grains are present in upper part of epidermis while rods are present in lower part of epidermis. Why? Because G comes first, it is present in upper part. R comes later, it comes in lower part. Now, grains all of you must have seen, isn't it? Grains like wheat grain, rice grain. If you keep it on the table, they are transverse. While rods, how we hold them? We hold them vertical. So rods are vertically elongated, grains are transversely elongated. And both these are seen in which condition? Darier disease. Okay. Now remember another point that Darier disease generally involves seborrheic areas. And what are seborrheic areas? Seborrheic areas are those areas where sebaceous glands are more, like scalp, face, behind ear, neck area, upper chest, upper back. So here is a patient suffering from Darier disease where rough keratotic lesions start developing. So clinically, you will find rough lesions, keratotic lesions, or verrucous, that is wart like rough lesions where over seborrheic areas. Seborrheic areas like scalp, behind ear, face, neck, upper chest, upper back. So this is the common presentation of Darier disease. Okay. Now this is not the only condition where seborrheic areas are involved. Seborrheic areas can be involved in various conditions. So what are those conditions where seborrheic areas are involved? So lesions follow seborrheic distribution in many conditions, like one I just now told you, that is Darier disease. So you can remember Darier disease. Other than Darier disease, there are other conditions also, like Langerhans histiocytosis, pemphigus foliaceus, then seborrheic dermatitis, and Darier's disease. So these are four important conditions where lesions follow seborrheic distribution or seborrheic areas are involved. Okay, now if you forget this in examination hall, you can very easily recall. How you're going to recall? Because you just need to recall this sentence, that is, lesions follow seborrheic distribution in lesions. L for Langerhans histiocytosis, follow for foliaceous, seborrheic for seborrheic dermatitis, and distribution D for Darier's. So you can see how easy it is to recall in the examination. Lesions follow seborrheic distribution in Langerhans histiocytosis, foliaceous type of pemphigus, seborrheic dermatitis, and Darier disease. So this point can also very easily be remembered in the examination. Now remember that nail changes are also very characteristically seen in this condition, and the nail changes are in the form of this V-shaped notching. So if you see the nail of these patients at the distal part of the nail, so if this is the nail of the patient, you will find that as the distal part there is V-shaped notching, which is very characteristically seen in Darier's disease. So all these findings can be seen in Darier's disease, but Darier sign is not seen. Darier sign is seen in Urticaria pigmentosa, like you can see in this child who is suffering from Urticaria pigmentosa, which is also known as cutaneous mastocytosis. Very obvious from the name itself. Cutaneous means related to skin. Masto related to mast cells. Cytosis means increased numbers. So there are increased numbers of mast cells in the skin. And these areas where increased numbers of mast cells are present appear dark. So this patient presents with pigmented macules or patches. And if you take a blunt object and start rubbing these patches, what will happen? These mast cells degranulate and release histamine, and due to which this area appears red, edematous, or urticaria like wheals start developing. This is known as Darier sign seen in urticaria pigmentosa or cutaneous mastocytosis. Very easy to recall in the examination that urticaria pigmentosa presents with pigmented lesions, as I have shown you here. They present with pigmented lesions, hidden in the name itself, pigmented lesions. And if you rub these pigmented lesions, what happen? They become red, edematous, wheals develop like wheals seen in urticaria. This is known as what? This is known as Darier sign. Okay, so if you forget Darier sign in examination, you can very easily recall Darier sign is seen in urticaria pigmentosa. Just reverse it. What is urticaria pigmentosa? That is pigmented lesions when rubbed produce urticaria like red wheals. This is Darier sign. Clear? Now, sometimes they ask you about another histopathological finding known as papillary tip microabscess. Now, these microabscesses are very important and already many times questions have been asked. So remember, micro means small and abscess are small collections of cells. So these small collections of cells are seen in dermatitis herpetiformis. Now, in dermatitis herpetiformis, these small collections of neutrophils start developing and they are generally present at the tip of the dermal papilla. So they are present where? At the tip of the dermal papilla. So that's why this is known as papillary tip microabscess seen in dermatitis herpetiformis. In psoriasis, another microabscess is seen known as Munro's microabscess or Kogo's pustules. Both these are seen in psoriasis. Both are due to collection of neutrophils. Then what is the difference? The difference is that Munro's microabscess is due to collection of neutrophils in the topmost layer, that is stratum corneum, while Kogo's pustules are due to collection of neutrophils in psoriasis in deeper epidermis, that is in Malpighian layer, that is lower epidermis like stratum spinosum, stratum basale. Generally, it is seen in stratum spinosum, so in the lower part of the epidermis. Then comes mycosis fungoides. Mycosis fungoides is a cutaneous T cell lymphoma. This cutaneous T cell lymphoma or mycosis fungoides is a malignancy. It is a lymphoma. So here collection of lymphocytes are seen, and these collections of lymphocytes are known as Poutrier's microabscess. So remember that Munro's microabscess is seen in psoriasis. Kogo's pustules are seen in psoriasis, while papillary tip microabscess is seen in dermatitis herpetiformis, and Poutrier's microabscess is seen in mycosis fungoides. But remember that these three, that is papillary tip, Munro's, Kogo's, they are collections of neutrophils. Poutrier's microabscess are collection of lymphocytes, while there is a very rare variant of pemphigus known as pemphigus vegetans. This is the rarest type of pemphigus, and here collection of eosinophils are seen. So collections of eosinophils are seen in pemphigus vegetans. So these are some more important points which you can remember about these different microabscesses. Generally, questions are asked on Munro's and Poutrier's. So if you ever forget between Munro's and Poutrier's, you can very easily recall that M is seen in P and P is seen in M, isn't it? Monroe's is seen in psoriasis, and Poutrier's is seen in mycosis fungoides. Now, which of the following test is useful in making diagnosis of pemphigus? All except. Again, see, examiner have written all except. So all are used in pemphigus except. And as you all know, Geratage test is used in psoriasis. So this is not used in pemphigus. This becomes the answer. While all these can come out positive in pemphigus, so they are used in pemphigus. Let us discuss them one by one. So, Geratage test. So let us consider that this is that erythematous plaque of psoriasis with silvery white scaling, and you took a glass slide and you started scraping it. When you scrap it, when you gerate it, that is when you start peeling it, what happens? This peel of white, silvery white scales start coming out. This is known as Geratage test. Now, if you keep on removing it, the end result is pinpoint bleeding spots, and this is known as Auspit sign. Auspit sign. Both these are seen in psoriasis. So Geratage test, Auspit sign, both are seen in psoriasis. The initial peeling of the scales is known as Geratage test, and the end result, that is pinpoint bleeding, is known as Auspit sign. Now coming to bulla spread sign. Let us consider this is the patient suffering from pemphigus, and this is the blister. So if you apply perpendicular pressure over this blister, or if you apply pressure on one side, you will notice that this blister extends on the other side. So this blister extends. This is known as bulla spread sign. Very obvious from the name itself. Applying pressure over the bulla spreads. This is known as bulla spread sign. But remember that this bulla spread sign is not specific of pemphigus. It is also seen positive in bullous pemphigoid. So this bulla spread sign can be seen positive in pemphigus as well as bullous pemphigoid. In both, it can come out positive. It is also known as Asbo-Hansen sign. So Asbo-Hansen sign or bulla spread sign, both are similar. Now coming to Nikolsky sign. Nikolsky sign is seen only positive in pemphigus and not in pemphigoid. So Nikolsky sign is only seen in pemphigus. And what is Nikolsky sign? If this is the blister and if you apply tangential pressure, that is the pressure parallel to the skin over the surrounding skin or any bony prominence, what happens? The overlying epidermis slides. This is known as Nikolsky sign. It come out positive in pemphigus but not in bullous pemphigoid. So this is more important than bulla spread sign because it helps in differentiating pemphigus and pemphigoid. Now coming to the last option, that is zinc smear. Zinc smear is a very simple procedure where when a patient comes with a blister, you can rupture that blister and take the scrapping from the base. And after doing Giemsa staining or right staining, you can see it under microscope. And if you find acanthocytes, then it is suggestive of pemphigus. But if you find multi-nucleated giant cells, then it is suggestive of herpes. So it is helpful in pemphigus and herpes. In pemphigus, acanthocytes are seen, and in herpes, multinucleated giant cells are seen. This is again a very favorite question of examiner. They ask you repeatedly in your screening exam, zinc smear. So remember this. Now, integrin and cadherin are important in the pathogenesis of. Now, all of you know that what antigen is involved in pemphigus. All of you know in pemphigus, desmoglin is involved. Like I told you, desmoglin 1 in foliaceous, desmoglin 3 and 1 in vulgaris. So desmoglin is involved. And what is desmoglin? Desmoglin is a desmosomal protein. That is, it is a protein present in desmosomes. There are other proteins present in desmosomes. Yes, there are other proteins which are present in desmosomes. So the proteins which are present in desmosomes are not only desmoglin, but desmocolin, desmoplakin, placoglobin, and placofilin. All these are desmosomal proteins. All these are present in desmosomes. So these are the names of the proteins which form desmosome, which are present in desmosomes, which help in attachment of two keratinocytes. And keratinocytes are present in epidermis. So all these are present in epidermis, that is intraepidermal. And that's why pemphigus is an intraepidermal blistering disorder, because the protein is also within the epidermis, in between the keratinocytes in the desmosomes. Okay, now all these proteins, as I told you, are desmosomal proteins, but these proteins belong to certain gene families, and the name of those gene families to which these desmosomal proteins belong to are integrin and cadherin. So remember that integrin, cadherin are the names of the gene family to which these desmosomal proteins belong, and these names of these desmosomal proteins are desmoglin, desmocolin, desmoplakin, placoglobin, and placofilin. And among them, desmoglin is very important, which is involved in pemphigus. So answer here becomes pemphigus. I hope this is clear. Now, photoonycholysis is seen as the adverse effect of. So remember that among these drugs, tetracycline group of drugs are known for photosensitivity. Photosensitivity. And one very specific type of photosensitivity is seen with doxycycline, which is known as photoonycholysis. Very obvious from the name itself. Photo means after exposure to light, onycho means nails, and lysis means separation. So after exposure with light, the nails of this patient start separating from the underlying nail bed, and this is known as photoonycholysis. This is a side effect associated with doxycycline. Here you can see this is the patient suffering from this side effect. Vitiligo is characterized by, now all of you know that vitiligo is an autoimmune condition. It is an autoimmune condition. Here certain antibodies are formed, and these antibodies go and destroy what? They destroy melanocytes, and that's why we call them anti-melanocytic antibodies. So anti-melanocytic antibodies are formed, and these antibodies go and destroy the melanocytes, and thus the melanocytes are absent. And when the melanocytes are absent, the skin loses all the melanocytes in that particular area. Once the melanocytes are gone, the melanosomes are gone. Once the melanosomes are gone, the melanin is gone. And once the melanin is gone, the color of the skin appears depigmented or white, something like this. So patients start developing depigmented or white patches. Why? Due to anti-melanocytic antibodies which go and destroy the melanocytes, and this area is deficient in melanocytes. So there is absence of melanocytes. This is the defect which is seen. Now, there are different types of vitiligo. The most common type is vitiligo vulgaris, where generally bilaterally symmetrical lesions are seen. But here in this image, you can see that the lesions are unilateral and they are along a particular nerve segment. So because the lesions are along a particular nerve segment and they are only on one side, this is the characteristic segmental variant of vitiligo. So this is segmental variant of vitiligo, though the most common variant is vitiligo vulgaris, where bilaterally symmetrical lesions are seen, like over both elbows, both knees, both shin. So symmetrical lesions are generally seen, but the lesions are similar, that is depigmented white in color, as shown in this image. Now, which of the following is true about acne vulgaris except, okay, so again, you have to tell the incorrect statement. So this is a disorder of pilosebaceous unit or follicles. Yes, it is correct. It is not just the disorder of sebaceous gland. It is the disorder of the whole unit, that is pilosebaceous unit. So this is the correct statement. It has familial tendency. Yes, true. It has familial tendency. There are many syndromes like Scapho syndrome which are associated with acne vulgaris. Then drug of choice for severe or nodulocystic acne is retinoid. Yes, because oral isotretinoin is the drug of choice, which is a type of retinoid. So this is also correct. And steroid induced acne are polymorphic. No, polymorphic. Poly means multiple, morphic means morphology. That is, different type of morphological lesions are seen in acne vulgaris, not in drug induced acne. The drug induced or steroid induced acne are generally monomorphic. That is, single type of morphological lesions are seen. So if the lesions are monomorphic, that is, if you're getting papules and everywhere papules are only present, then it is suggestive of drug induced acne like steroid induced acne. Okay, but if there are different types of lesions, like there are papules also, there are pustules also, there are comedones also, then it is the most common variant, that is acne vulgaris, where polymorphic lesions are seen. So this is the wrong statement and this becomes the answer, because they are asking all are true except, and this is the wrong statement here. All except causes non-scarring alopecia. Non-scarring alopecia. Now, there is a very easy mnemonic which I generally tell my students, that whenever question comes on non-scarring alopecia, which is also known as non-cicastaceal alopecia or temporary type of alopecia, because it can be treated. Okay, so this is non-scarring alopecia. Non-scarring alopecia generally occur in those skin conditions which start with these alphabets. And remembering these alphabets is very easy because I am going to give you a mnemonic here. And the mnemonic is Tata Sky HD. So Tata Sky HD, all those alopecias which start with alphabet A and T, like anagen effluvium, telogen effluvium, trichotillomania, alopecia areata, androgenetic alopecia, alopecia areata, then tractional alopecia, then non-inflammatory type of tinea capitis. All these are starting with A and T. So these are what? These are non-scarring alopecia. So A and T both are what? Non-scarring alopecia. Very easy. These are also known as primary type of non-scarring alopecia. Now, secondary means that is some secondary condition or systemic condition is present which is causing this type of hair loss. Like these secondary causes generally start with alphabet S, H, and D, like SLE, like secondary syphilis where moth-eaten alopecia is seen, then hypothyroidism, hyperthyroidism, and hyperpituitarism. Then certain deficiencies like deficiency of zinc, iron, biotin, all these can also cause non-scarring type of alopecia. So these are the 5 alphabets which you have to remember. And if any of these options are starting with these 5 alphabets, they are example of non-scarring alopecia. So these alphabets are A, T, S, H, and D. If you look at these 4 options, A, S, and T are present. All these 3 are non-scarring alopecia. The answer becomes DLE, where scarring alopecia is seen. Scarring alopecia means cicastaceal alopecia, permanent type of alopecia. Once the hair follicles are gone, they cannot come back because this is permanent type. Now remember, DLE also have some more features. Along with scarring alopecia, you will find scaling here. So lesions have scaling. This scaling is very adherent. And if you try to remove this, you can see plugging beneath the scales. This is known as carpet tack sign. And in the treatment of this condition, we use hydroxychloroquine. And this condition generally occurs over sun exposed areas. All these are the features which are seen in DLE. DLE stands for discoid lupus erythematosus. SLE is systemic lupus erythematosus. This is localized variant, discoid lupus erythematosus. And as you can see here, the third alphabet is S. So you can remember 3S: scarring alopecia, scaly lesions, occur on sun exposure sites, and another alphabet is C. So you can remember 2C, that is carpet texine, and chloroquine is used in the treatment. So very easy to recall these points related to discoid lupus erythematosus. 5-year-old male child with multiple hyperpigmented macules over trunk. So patient is having dark colored lesions over trunk. On rubbing these lesions with the rounded end of the pen, so on scraping these lesions, patient develops articarial wheal confined to the border of the lesion. What is the diagnosis? So we have already discussed this. I told you that pigmented lesions, when rubbed, produce red wheals like articaria. What we call it? Articaria pigmentosa. Answer is Articaria pigmentosa. So everything is hidden in the name itself. Articaria pigmentosa. Wheals are seen in articaria, and here pigmented lesions are seen which rubbed and then they produce wheals or red lesions. So this is known as Articaria pigmentosa. And what this sign is known as? This sign is known as Darier sign. So very important to remember that Darier sign is not seen in Darier disease. It is seen in this condition, that is Articaria pigmentosa. Now they ask you sometimes the markers of Langerhans cells. So these markers come out positive in diseases related to Langerhans cells like Langerhans cell histiocytosis. And the markers are CD1A, CD207, and S100. All these three are markers of Langerhans cells or Langerhans cell histiocytosis. Among them, this is also known as Langren. So another name of CD207 is Langren, and this is the most specific marker. Questions are also asked on CD1A. This is a marker of Langerhans cells. Then 40-year-old woman presents with a 2-year history of erythematous papulopustular lesions, that is papules along with pus-filled lesions on the convexities of the face. Do you know any condition which occur on the convexities of the face like cheek, nose, chin? Yes. And there is erythema and telangiectasia, that is there is redness along with superficial dilated blood vessels. What is the diagnosis of this condition? So remember that acne vulgaris can occur over face, but not necessarily convexities of the face. So this is not the answer. SLE can develop over face, especially where over they form butterfly rashes, that is cheek and nose. So there is a characteristic butterfly rashes along with, this is a systemic condition. So there is history of fever, then there is history of joint pain, there is history of photosensitivity. So generally on sunlight exposure, it aggravates. And remember that this spares nasolabial folds. So these are some characteristic features of SLE butterfly rashes. While polylight eruptions are due to excessive sunlight exposure, so they generally occur where they generally occur exposed areas. So they develop over exposed areas. So these are not the answer. The correct answer here is acne rosacea, or simply known as rosacea. And rosacea is a condition which generally occur over convex areas of the face. Here, papulopustular lesions can be seen, and it can involve nasolabial folds. So this helps in differentiating from SLE. Nasolabial folds can get involved. Here in acne rosacea, there is role of a mite, Demodex mite, which infiltrates the pilosebaceous unit, and that's why the drug of choice for this condition is metronidazole. This is how these patients present. They generally present with red areas, that is erythema, along with telangiectasia, that is superficial dilated blood vessels, where over convex areas like face, nose, chin, so convex areas of the face are involved, and nasolabial folds can also get involved in this condition. Okay. Female with painful, long-standing, persistent oral lesions. So patient is having painful, persisting for a long period oral lesions with suprabasal acantholysis. Acantholysis, that is separation of keratinocytes, and separation of keratinocytes is a feature which is generally seen in pemphigus. Now there are two major types of pemphigus, foliaceous and vulgaris. Foliaceous and vulgaris. Which type of separation is seen in foliaceous? It is subcorneal. And which type of separation is seen in vulgaris? It is suprabasal. And that is what they are asking. Suprabasal acantholysis is feature of pemphigus vulgaris. One of the option is pemphigus vulgaris here. So answer becomes pemphigus vulgaris. Aphthous ulcer can present with painful oral lesions, but it is generally not long standing. They easily resolve. Then erythema multiforme presents with target lesions. Target lesions, that is, lesions have multiple concentric rings, and it generally is followed by viral infection, usually herpes virus infection. And bullous pemphigoid never have acantholysis because this is a subepidermal disorder. Epidermis is not involved, so acantholysis is not seen. So that's why these are not the answer. 24-year-old unmarried women. Why unmarried? Because the drug is not used in married or pregnant females. So the patient who want to conceive, or patient is married and planning to conceive or is pregnant, we should avoid this drug. So that's why this point becomes very important. It has multiple nodules, cysts, pustules, comedons. Comedons are the characteristic lesions of acne. So as soon as you see comedons, you know that the patient is suffering from acne. And upper back and shoulders are also involved. What is the drug of choice? So we know that in nodulocystic acne, that is severe type of acne, the drug of choice is isotretinoin, and it is a teratogenic drug. Teratogenic drug, so it should be avoiding during pregnancy, but the female here is unmarried, so that's why you can easily give this drug and counsel the patient that whenever she's planning to get married, she need to stop this drug. So oral isotretinoin will be the drug of choice here. So you can see sometimes patient can develop very large nodules and cysts. This is known as nodulocystic acne, grade 4 acne, severe type of acne, and in this acne, the drug of choice is oral isotretinoin. The commonest sign of nail psoriasis, the most common change which is seen in the nails in a patient of psoriasis is nail pitting, and this pitting is irregular and deep. While if there is regular pitting, then it is suggestive of alopecia areata. Pterygium is the most characteristic nail change seen in lichen planus. Oil drop sign is the most characteristic change seen in psoriasis. So remember that in psoriasis, the most characteristic is oil drop sign, also known as salmon patch, and the most common is pitting. While onycholysis is seen in psoriasis as well as onychomycosis, that is fungal infection of nails. So all these are the nail changes which can be seen in different conditions. But remember what the examiner is asking. If the examiner is asking the commonest in psoriasis pitting, most characteristic in psoriasis oil drop sign, most characteristic in lichen planus pterygium. So here you can see these deep irregular pits which are present in a patient who is suffering from psoriasis. Along with there is onycholysis, due to which the nail plate have separated, and due to which it is appearing yellowish in color instead of pink color. So you can see pink color here, but yellowish color here. Why? Because of onycholysis. Leukonychia can also be seen. See, itchy vesicles on palm and sole of an adult male is seen in. So as soon as you see itchy, you suspect scabies, where very severe nocturnal pruritus is seen, but this is not scabies. Why? Because palm and sole are spared in adults. So when adults suffer from scabies, palm and sole are spared, though they can be involved in infants. So in infants suffering from scabies, palm and sole can get involved, but in adults, they are spared and the patient is adult. So this is not scabies. Second, sweet syndrome. Sweet syndrome is associated with tender nodule over face, not necessarily itchy and not necessarily palm and sole are involved. Vesicles are not necessarily seen. They generally present with tender nodules over face. It is usually associated with underlying malignancy like acute myeloid leukemia. So all these are not feature of sweet syndrome. Then syphilis. Now remember that vesicles are written here, and vesicles are not seen in syphilis except for one type, and that is early congenital type of syphilis. So vesicles are never seen in syphilis except for one variant, and that is early congenital type of syphilis. So only in very young children less than 2 years of age who are suffering from early congenital type of syphilis, you can find vesicles, but here vesicles are present and the patient is adult. So this is not syphilis. So now you know that you have excluded all the three options. You are only left with one option, and that is Pompholex. And Pompholex is only condition which can be itchy, which can present with fluid-filled lesions, usually present over palm and sole, and it is type of hand and feet eczema, where these fluid-filled lesions start developing over palm and sole of the patient, something like this. And these fluid-filled lesions are slightly deep, so they are generally not better seen, but they are better felt. So this is when you palpate them, they give a characteristic sago grain like feel. So sago grain or tapioca feel is seen in Pompholex. So if you palpate this palm of the patient, you will feel as if there are sago grains, sabudane jaisi feel aati hai. 8-month-old child presents with diarrhea, alopecia, rash on acral and periorificial areas. What this condition is? Yes, this condition is acrodermatitis enteropathica, which is due to zinc deficiency. It is due to zinc deficiency. And how do you know it is acrodermatitis enteropathica? Because the name itself is suggestive. Entero means intestine. So one feature is related to intestine, that is diarrhea. I told you that deficiency of zinc, iron, and biotin can cause non-scarring alopecia. So you can see there is alopecia present. Then patient is having dermatitis, that is inflammation of the skin, where over acral parts, name itself is suggestive, acro. So acral parts are involved along with face and groin area is also involved. So you can see every feature is written in the name itself. The name is acrodermatitis enteropathica, which is due to zinc deficiency. This is how these children present. They present with this dermatitis, that is inflammation of the skin. So skin becomes red, shiny, inflamed over periorificial, that is over the face, around the mouth, over the diaper areas, and also acral parts can get involved, that is hand and feet can get involved. This is a condition which occurs due to zinc deficiency. So what is the treatment? You simply need to give zinc supplement to this patient. So I hope this session was useful for all of you, because I have discussed most of the high yield topics and various questions from different topics of dermatology. So thank you very much. All the very best for your exam. I hope all of you will pass this exam. So my best wishes are with you. Thank you.